Hi, I'm Kristen Hodgden, IVF mom, proud women's health advocate, and co-founder of Rescripted.
And I'm Dr. Jenna Khan, a board-certified OBGYN, fertility specialist, and mom of two.
And from first period to last period, we're diving into the women's health topics that matter most, from periods and fertility to pregnancy and menopause.
Through expert interviews and candid conversations, we're empowering women to take charge of their health by expanding the discussion beyond what's typically covered in the doctor's office.
It's time to stop guessing when it comes to our health. Now let's dive in for the real science-backed info you need to be the expert in you. Hi, everyone, and welcome back to From First Period to Last Period. I'm Kristen.
And I'm Dr. Jenna Khan.
And we're back with an amazing episode. But first, let's talk about what's on our minds. So my IVF baby turned 3 months today. And I have been telling my co-founder how it feels like the end of the fourth trimester, even though that's not something that is widely talked about. But I don't know. It feels like a big milestone to me.
For sure. Yeah. They start becoming like little people and they start to sleep a little bit more. You start to learn a little bit about their personalities and you feel like you can finally breathe a little bit.
Yeah. And this postpartum experience was so different for me. Last time I really suffered from a traumatic birth and postpartum anxiety. And I felt like after a long infertility journey, I was waiting for the other shoe to drop. And this time it felt like such a different experience. I feel like my biggest symptom or postpartum symptom this time around was brain fog.
Of course. And you have two older kids that you're thinking about their schedules and the baby. It's a lot. And then also your body healing from a new experience. It's chaos.
It is chaos. And I keep saying that the baby is the easiest one. My son had to get glasses last week. I'm dealing with a situation at school with my daughter. I'm like, okay.
Sure. Remember when your twins were little, babies, and every little thing you were so nervous about and thinking about every little twitch and sound. And then with the second, you're just like, oh, they're fine.
No, yeah, absolutely. And
or the third.
Little kids, little problems, big kids. I mean, they're not even big kids yet, but big kids, bigger problems.
Yeah.
I feel like I felt so terrible last week that my son was basically half blind and I didn't know for the longest time. So yeah, but it definitely feels like, okay, we made it through the first 3 months and it's only up from here,
For sure.
So what's going on with you, Jenna?
So I am gearing up for my last set of boards for reproductive medicine, which is crazy.
That's exciting.
Yeah, you once you pass all of your general OBGYN boards, which is a written and an oral set, then you have to take them for reproductive medicine, REI. So I've passed my written boards, and then, you've got to be in practice for a couple of years before you get the privilege to fly down to Texas and defend your life in front of a couple people. So I'm preparing for that, which is in early April.
That's amazing. I mean, you've been through so much school at this point, and it must feel like the culmination of everything you've done up to this point.
It's crazy. It's crazy. And, I've been stressing about this, studying every weekend. And then, I'm now starting to do some practice exams and I'm like, I know this, it's going to be okay.
Yeah. Yeah. Well, yeah. And you're practicing it every day.
Exactly. That's it's more clinical rather than, the nitty gritty of, the textbook stuff.
Okay. So that was more of the written exam.
Yeah.
Well, you heard it here. If you are looking into fertility specialists, they have a ton of education and they have to pass multiple exams.
Yeah. Double board certified.
Yeah. So you're in good hands. Well, awesome. Well, we have an amazing episode coming up. Katherine, I know you said, Jenna, that you wanted to give a round of applause after you heard her story. She's going to be sharing her experience with a rare molar pregnancy. Spoiler alert, her story has a happy ending. Then in Own Your Health, we're going to take you through the difference between BV and a UTI, because sometimes they feel like one and the same. And when it comes to nutrition, registered dietitian Anna Bonengel is going to explain what the deal is with intermittent fasting. And lastly, in women's health in the wild, we're going to dive into new research that confirms that BV may actually be a sexually transmitted infection. I'm really excited to talk about that one. It feels like kind of a game changer when it comes to treatment for recurring BV. So yeah, let's jump right in. Her Story Unfiltered, raw, real, and rescripting women's health, one powerful story at a time.
Starting a family should be one of life's happiest moments, but things don't always go as planned. That's exactly what happened to me when I thought I was pregnant for the second time. After one heartbreaking miscarriage, I tracked my cycle obsessively for months. Finally, I saw those 2 pink lines. I was pregnant again. But my excitement turned into something I could never have prepared for, a molar pregnancy. For those who don't know, it's a rare complication where the egg is fertilized incorrectly by the sperm. While most cases are managed with a DNC, in rare situations, the tissue can develop into something more serious, choriocarcinoma. That's what happened to me. After my first DNC, my blood work improved and I felt optimistic. But weeks later, I woke up with intense cramps and started passing blood clots. Another ultrasound revealed a piece of tissue had regrown and I needed a second urgent DNC, this time fully awake. 2 DNCs later, I received the diagnosis no one expects: cancer. The odds, 1 in 50,000. Within weeks, I had a port put in my chest and began chemotherapy. The treatments were weekly, grueling, and emotionally draining. Some days I leaned on incredible support. Other days I felt utterly lost. Chemo is brutal both physically and emotionally. After months of treatment, I was finally cleared to try again for a baby, but the wait felt endless. When the time came, more heartbreak followed. My egg reserve was low, and my chances of conceiving naturally were slim. I hit rock bottom. Baby announcements, showers, and milestones felt like painful reminders of what I might never have. My husband and I started dreaming of a different future, one without children. We talked about moving to Telluride, starting fresh, and focusing on a life beyond fertility struggles. It was a step towards healing. And then life surprised us. 9 months later, I gave birth to our daughter, Kate. She is now almost 3, and just 21 months after that, we welcomed our son, Lewis. No interventions, no treatments, just life happening. Looking back, the journey was excruciating, but it shaped who I am today. And for anyone facing similar challenges, I hope my story reminds you that hope can sometimes appear when you least expect it.
Oh my gosh.
Right? Don't you just want to give that a round of applause?
I
That
do.
was
I
so
really
good.
do. Thank you, Katherine, for sharing your story and for shining a light on molar pregnancy. I've heard of it before, but I actually didn't realize the part about the DNC tissue. Um, can you kind of go into that, Jenna, and like how molar pregnancies kind of come to be? I know they're pretty rare.
Yeah, so molar pregnancies are super rare, like 60 to 100 cases per 100,000 pregnancies. They come about from abnormal fertilization of an egg. And so Katherine sort of got into that a little bit. So you can have a fertilization of an empty egg with no genetic material in it by a sperm and then like duplicated DNA of that one sperm.
Mhm.
You could have multiple sperm fertilize an egg. And it kind of comes in 2 flavors. There's a complete mole and a partial mole. Complete moles are a little bit more complicated than partial moles, but excuse me, complete moles, they have really, really high pregnancy hormone levels. There's no formation of pregnancy of an actual pregnancy, so you don't see like a fetus or a heartbeat or anything like that. It can be associated with like a rapid growth of the uterus, vaginal bleeding, severe nausea and vomiting, hyperthyroidism actually from the really, really high HCG levels. And the complete moles are actually have this 15 to 20% risk of choriocarcinoma afterwards, whereas a partial mole is a little less severe but still needs some surveillance. So partial mole, you actually do have some like a fetus develop, but it is chromosomally abnormal, usually triploid, so like 3 sets of chromosomes. And sometimes you see a heartbeat too, but these often will miscarry. And they're often just like diagnosed as a miscarriage, but the diagnosis of a partial mole isn't actually made until a pathologist reviews the tissue from a D&E. And the risk of choriocarcinoma in after a partial mole is like 1 to 5%. So molar pregnancies are really rare, but
Mm-hmm.
they are pretty serious. And so when you are suspecting a molar pregnancy based on really, really high HCG levels or symptoms or what you see on ultrasound, then it's really important that you get that tissue on a D&E rather than like medical management of a miscarriage. And you send it to pathology for the confirmation and then have that surveillance. So what I mean by surveillance is we're trending the pregnancy hormone level pretty consistently. So, like on a weekly basis until the pregnancy hormone level gets to 0. And then, if you have a complete mole, then you've got to make sure it stays at 0 for at least 6 months before you start trying again. And with a
Mm-hmm.
partial mole, it's got to be negative for at least a month before you start trying again, just because of that risk of developing that, what we call gestational trophoblastic neoplasm, or the cancer that can come afterwards.
That is so crazy, especially when you're on an infertility journey. I feel like the last thing you expect from a miscarriage is cancer,
For
and it
sure.
just
You're
adds
like,
salt to the
how
wound.
did I get here? How did this happen?
Yeah, absolutely. But obviously, I mean, obviously in Catherine's case, it all worked out with getting pregnant unassisted after the fact. But is that rare, or what would
No,
you
so I
say?
mean, the most common thing is that they'll get pregnant with a healthy pregnancy in the next pregnancy. But if you've had a prior molar pregnancy, then that is a risk factor for having one again, or,
Okay.
increased risk for another one. And so future pregnancies should be monitored a little bit more closely just to make sure that they're developing appropriately and there's no concern for a molar pregnancy. But yes, most of them will develop, most subsequent pregnancies will be normal. And the part that I just loved about her story is highlighting that a low ovarian reserve does not predict ability to get pregnant. And sure, you could be scared by like a low AMH level or low markers of ovarian reserve and feel like there's no hope in sight, but really this is a great example that low ovarian reserve does not predict ability to become pregnant, and someone
Mhm.
with a low ovarian reserve may very well become pregnant sooner than someone with a very high ovarian reserve.
Yeah, I love that. We talked a little bit about like at home fertility testing in one of our previous episodes. So definitely go back and check that one out if you're interested in learning more about this. But yeah, I think I mean I see stories all the time in our community of people who like were told by a doctor that they could never get pregnant naturally, and then or actually I don't like to use the word naturally, unassisted.
And yeah,
um and then they go on and it happens. And you never want to say to anyone like, oh, so and so just relaxed and stopped trying and didn't think about it and got pregnant. But there are like, what's the actual percentage of people that kind of go on after maybe like doing IVF in a previous pregnancy, or not being able to get pregnant, and then all of a sudden after treatments they get pregnant?
I haven't looked at this in a while, but I think if you have like unexplained infertility and went through IVF,
Mm-hmm.
about 1 in 5 patients will actually get
Yeah,
pregnant in an unassisted way with a second pregnancy.
that's crazy. That's a big percentage.
Yeah, yeah. So
Yeah, and
I
then
think that, but some people, I'm sure you could speak to this, have PTSD from the whole experience and don't want to leave it up to chance to try for, another year to see if they can get pregnant for their next kid.
no, I actually feel very adamant that I'm like 99.9% sure we're done, but I like feel very adamant that I do not want to leave it up to chance. Like I have PGTA tested embryos in the freezer, and if I do decide, or if we do decide that we want another one, like I will be using one of those and not.
Right. Have it like a controlled situation where there's like more of a much higher chance of success rather than rolling the dice.
Yeah, and like I don't know. I'm also in my late 30s now, and um just knowing egg quality declines and there's a higher risk of miscarriage, and I don't know, all of the
All the
above.
reasons, all the good reasons. Yeah.
Yeah. And like, if there's one silver lining to IVF, it's like, I really think like kind of PGT testing and having that, obviously not,
Sense of control.
yeah, it's not 100% guarantee ever. I mean, I've had a miscarriage with a PGT normal embryo, but um, just a little bit more control. Yeah, like you said.
Yeah.
Yeah. Well, thank you again, Catherine. I'm so happy you got your sweet family at the end.
Own your health. Ask us anything. Your questions and expert answers, because you are your own best advocate.
Okay, we got a ton of great questions today from our Own Your Health audience. One of them is all about BV versus UTIs. We actually have an article about this on our site too, but I think a lot of people get them confused. Both are pretty common. So someone wants to know, BV or UTI, how do I know the difference? And I guess if you could talk, Jenna, about like how rare each is and like just what the treatment options are for both, like how they differ in that way.
Sure. So they're both actually pretty common in reproductive sexually active women.
Mm-hmm.
So BV, it stands for bacterial vaginosis, and it's actually not an infection. It's a condition that's caused by a disturbance in the pH, or the natural acidity of the vagina, leading to an imbalance in the types of normal bacteria that live there. So there's always a balance between good bacteria and bad bacteria. And when that natural acidity changes, there can be an increase in that bad bacteria that grows. Some things that may change the pH are new soaps or detergents, douching. Side note, don't do this. The vagina is a self-cleaning oven. Don't put anything up there. And new sexual partners. So the main symptom for BV is increased discharge with a strong fishy odor. The odor may be stronger during the menstrual period or after sex, and the discharge is usually thin or dark, like a dull gray, and sometimes might be greenish in color. Itching is not that common unless there's like a lot of discharge, and that discharge itself can be a little irritating. And although it's not like an infection per se, it actually is treated with antibiotics in the form of a pill or a vaginal gel. Metronidazole is the first line use. And if the primary source of the pH imbalance is not removed, like you're not changing your soaps to what you were using before, or your detergents, then BV can reoccur.
Yeah.
And so later in the episode, we'll talk about the great article about treating sexual partners. I still wouldn't classify this as like a sexually transmitted infection, but certainly different partner semen might change that pH, and then your body might react differently. So very excited about that coming up. And then UTIs, or urinary tract infections, is a bacterial infection of the urogenital tract, which means the urethra, the bladder, the kidneys. And these are really common in women because the vagina and the rectum are so close to the urethral opening that any like foreign bacteria can easily move from one location to another, especially like after sex. Most UTIs do not end up extending to the kidneys because UTIs limited to the bladder can be extremely uncomfortable. So treatment is usually initiated before the infection progresses into the kidneys. This is actually a little different in pregnancy, where patients are less likely to feel that discomfort in the bladder. And so they're actually more likely to develop a kidney infection because it's just not treated at the bladder stage. Yeah. So symptoms of a UTI are burning with urination, urinary frequency, like feeling like you have to go all the time, urgency, like feeling like you won't make it to the bathroom to empty, in time. And UTIs are not associated with vaginal discharge. They're not really associated with itching. So they actually are very different. But I think some women are just like, something's happening down there and I'm not really sure what it is, and so
I've always equated a UTI with like feeling like you have to pee all the time, but not actually being able to
yeah,
go,
yes,
which is so uncomfortable.
the worst. Oh, it's the worst.
Yeah, I've never actually had BV, but I know that that is kind of just different type of discomfort.
For sure. And UTIs are treated with antibiotics, different antibiotics than you would treat for BV, because it's different flora that live in the in the reproductive tract, and in like the rectum and then the bladder. And UTI reoccurrences should really be evaluated by a doctor.
Mm-hmm. Is it true that you should always pee after sex because to prevent UTIs?
I think it's a little different for everybody, but if you're getting UTIs, then peeing after sex can be really helpful, just to like sort of flush the urinary tract of any bacteria that might have sort of gotten up there after sex. That
Yeah.
can be a really helpful, easy step.
Yeah, I feel like it's just like something that's stuck in my head. Like you have to do it.
Like
It's a
prevents
rule.
UTIs. And I think once you have your first UTI, you're like, I never want this to ever happen again. And so it sort of just becomes a habit to pee after sex.
Yeah. Yeah, everyone pee after sex to prevent UTIs, just in case. So someone else wrote in, they must be having really heavy periods because they asked how heavy is too heavy when it comes to period blood.
So heavy menstrual bleeding is like really defined as excessive menstrual blood loss that interferes with a woman's physical, social, and emotional quality of life. The exact amount of blood varies. Heavy bleeding is generally considered to be a blood loss of more than 80 milliliters per menstrual cycle, but like no one's like going around measuring, that's 80 milliliters is, in like a visual term, is more like 5.5 tablespoons or a third of a cup, or like in like feminine product visualization, it's like roughly 16 fully soaked regular sized tampons or pads, or filling a 30 milliliter menstrual cup at least 3 times in a single period.
Wait, 16 pads or tampons in the course of your whole period?
In the course of your whole period, but like fully soaked, not like a little. Usually like the first few days are pretty heavy and then it sort of tapers off. So if you're having like more than 4 fully soaked tampons a day for 4 days in a row, that is considered heavy menstrual bleeding.
I feel like some people with like endometriosis or like really heavy periods are like, I do more than that.
Yeah,
so
and like it might not that might not necessarily impact your life, and that's why they said like the exact amount varies.
Yeah.
But bleeding more than this often can disrupt daily activities, cause significant discomfort, and lead to other health problems like anemia.
Yeah.
And so signs of heavy menstrual bleeding would be bleeding that lasts longer than 7 days, soaking through pads or tampons every 1 to 2 hours, passing blood clots that are larger than a quarter, feeling tired, weak, or short of breath. These are symptoms of anemia, and having to change pads or tampons during the night. So if you're having any of those symptoms and you're, not feeling quite like yourself or feeling fatigued, that would be a reason to go see your OBGYN to assess this.
So if a patient came to you with like really, really heavy periods, would you kind of do a full workup, like maybe dive into whether endometriosis is a factor, or would you, depending on if they're trying to conceive or not, like recommend birth control?
Yeah. So heavy bleeding can come from a lot of different things. It can come from like not having regular periods and not having like an even shedding of the lining, like in patients with PCOS who are on birth control and just are like not getting a period ever, except for like 1 or 2 times a year when they've got like crazy heavy flows. Like that's a reason for heavy bleeding. Fibroids, adenomyosis, endometriosis, polyps, like these are all causes of really heavy bleeding that can be assessed with ultrasound and hormonal testing. And so, yeah, I would go through, the workup, and then just like most other hormonally related problems, that are treated with birth control pills. That's sort of similar to this, where you can actually stop the bleeding with continuous birth control pills and allow someone's blood count to build back up so they're not feeling so terrible from anemia. If there's a polyp, we can remove the polyp. If there's fibroids, the fibroids could be removed. You could also like treat the actual problem.
Yeah.
And then there's also IUDs, like a Mirena IUD, which is actually FDA approved for heavy bleeding, which is just like an amazing, amazing treatment option too.
That's awesome. I feel like I'm learning so much about IUDs on this podcast. Like I kind of just always equated them with pregnancy prevention and not like all of the benefits that you've described. So
for sure.
It's exciting.
They're great.
Not to get too personal, but like because when you talked about PCOS and irregular periods, like if I'm 3 months postpartum and not breastfeeding, is it abnormal to not have gotten my period back yet, keeping in mind that I have PCOS?
No, that's not abnormal. I mean, why would you expect to get a period now if you don't usually get one on your own beforehand,
That's true. I think like it's like that infertility mind F where you're like, oh, my body's just going to regulate after giving birth. Like, because you hear it, we talked about it earlier in the episode, like you hear it happen sometimes. But yeah, I'm kind of like getting to the point where I'm like, maybe I have to consider birth control again. So we'll see.
Yeah, and there's a lot of options, you can, and this is really like for endometrial protection, whether you're on birth control pills or an IUD, or every couple months you do like a Provera withdrawal bleed, just something to sort of keep the lining fresh and from abnormal cells from building up.
Yeah, well, last time I gave birth, I didn't do anything for like 8 months and ended up getting like the worst period of my life. So I would like to not have that.
And that's sort of what I was getting at with with PCOS. If you don't have a bleed for a long time, that lining can build up, and then when you do have a bleed, it's like, a murder scene. It's a lot.
Yeah, and that's really triggering to me because I had like a postpartum hemorrhage and all that stuff, and it was like not a good situation. So yeah, I have to start thinking about all of that stuff, which I'm just so like over hormones. Like I don't want to.
It's nice not having to think about it.
It is kind of nice not having to think about it. Yeah, one perk of pregnancy, and yeah, but it is what it is. PCOS problems. So we have our friend Anna Bonengel, registered dietitian, joining us again today to talk about intermittent fasting. I'm excited to hear this one. So let's take a listen.
There is research suggesting that intermittent fasting can be helpful specifically for a sedentary population dealing with metabolic conditions like prediabetes and obesity. However, and here's the but I know you're waiting for, research does not show additional benefits from intermittent fasting for populations already exercising. So if you already exercise, meaning you move on purpose, intermittent fasting is not likely to impart any additional benefits. Now, for women who exercise, the impact of intermittent fasting can even be harmful. For women more so than men, when facing nutrient deficiencies or perceived food scarcity, our body responds by increasing our appetite and decreasing our insulin sensitivity. Decreased insulin sensitivity means greater fluctuations in blood sugar. That like roller coaster that makes you feel tired, irritable, and hangry. Fasting places stress on your body, causing an increase in the stress hormone cortisol, an effect that's even more pronounced in women. An excess of high cortisol can suppress thyroid levels, which can lead to a cascade of issues from missing periods and infertility to weight gain and depression. So in sum, to reap all the metabolic benefits without the risk, women need to nourish themselves regularly and consistently.
I love the constant message from Anna to like eat enough food. It's like everything we were told in diet culture is wrong, and we need to eat food to balance our hormones and just, keep our metabolic
health. And, I sort of feel like, on like a personal level, it growing up in that diet culture, it's like really changing the way that you think about food, and nurturing yourself with well-balanced diet, whole grains, fruits, vegetables, proteins. Like it is so important for so many different parts of your life, especially your reproductive life, to get healthy regular periods and have that healthy brain ovary communication.
Yeah, and I like how she's called exercise moving on purpose.
I know.
Because I personally love exercising. Like I didn't used to, like in my early 20s, avoided it at all costs, and now it really helps with stress relief for me more than anything, like mental benefits, especially strength training and Pilates. And like if you're already in like that calorie deficit, then if you're starving yourself, you know, that isn't good
There's so many
for
like unintended
anything.
downstream effects that are just not worth it. Like you can maintain a healthy lifestyle and a healthy weight by really adding in healthy things rather than taking them away.
Yeah, I feel like giving birth and being pregnant kind of, and infertility, IVF, like just seeing what my body was capable of, like really changed my relationship with my body. Like I have such an appreciation for it now that it can do all these hard things. And I'm constantly telling my kids, like, you can do hard things. um, but I don't know. I used to like think about every little thing that I put in my mouth. And now it's like, I really do think of it as nourishing my body versus like trying to deprive myself.
For sure.
Women's Health in the Wild, must reads, must sees, and must tries for your wellness journey.
So I'm really excited about this week's Women's Health in the Wild section. This is actually kind of like breaking news over the past couple of weeks. There's a groundbreaking new study that was published in the New England Journal of Medicine, which reveals that treating both women with bacterial vaginosis and their male partners significantly reduces the recurrence of the infection. So wanted to ask you as a fertility specialist, Jenna, like how much of a big deal is this? Like, I think I hear a lot from people in our community that like BV, it's not usually just like a one-time thing. A lot of times it comes back and it's really uncomfortable, and it really kind of interferes with how you feel about yourself. And this feels really like a big deal that okay, men are part of the equation too, and we
For
can't
sure. I
just
think,
blame everything on the vagina.
yeah, I think this is a really big deal. Like, first and foremost, this was published in the New England Journal of Medicine, which is a big deal. And although
Yeah.
it was a sort of a smallish study, like 150 couples, I believe, were assessed, randomized. It was a randomized trial. It was a really well done study, and so that sort of speaks volumes in terms of how much confidence we put into the results and how it changes our management strategies. And so I think one of the biggest things that caught my eye in this study was that so every randomized control trial has a data safety and monitoring board that like monitors the outcomes as they're happening to make sure that there's no significant harm in the treatment group. And the trial was stopped by this data safety monitoring board after 150 couples were completed the 12-week follow-up period, which is less than what they intended to study, because the treatment of the woman-only group was inferior to the treatment of both women and her male partner. So treatment of both the woman and the man was much better than treating of the woman alone, which I think speaks volumes as well. And so recurrence occurred in 35% of the partner treated group and 63% of the control or woman only group. And so that's almost a 50% reduction in recurrences, which is huge. And I think sort of like, oh, go ahead.
No, I was gonna say for sure. Especially if you have the same partner, it's like you're passing it back and forth.
Yeah, and sort of like what I was talking about before, whereas like BV is often recurs if you're not removing that source of the pH imbalance, and you're not going to remove your partner. You like love your partner, like you can't like not be intimate with them. That's not a solution. So what do you do? Suffer through recurrent BV? That sounds horrible. And so this is a huge finding for a lot of couples out there. And I certainly feel like from this data that I will be incorporating this into my management for patients with recurrent BV.
Love that. And I was kind of startled to see the statistics about BV, like never having experienced it myself. Like it affects 20 to 30% of women of reproductive age. It's like a third of women. And if, it's recurring too, that's just like a widespread problem.
Yeah, it can certainly be very distressing and make women really self-conscious about this odor that they're having. And I think it makes sense to include the partner in the treatment if they're maybe thought to be contributing to the cause, or if you don't know what the cause of recurrence is, treating the partner as well may help.
Awesome. Love new research and new treatments for things that plague women. I mean, like one less thing to worry about, right?
Definitely. I still think that there's always more work to be done, but even these small studies that are well done are really helpful to our field.
Love it. Well, thanks, Jenna. This is a great episode, and we'll chat next time.
See you soon.
Thanks for tuning in to From First Period to Last Period. If you enjoyed today's episode, be sure to hit subscribe so you don't miss any of our future conversations.
And don't forget to share this with your friends, because when it comes to women's health, we all deserve to be informed, empowered, and supported.
Still have questions? Email community@rescripted.com for a chance to have yours answered on a future episode. For more science-backed women's health content that meets you exactly where you are, head to rescripted.com or follow us on social @HelloRescripted.
We'll see you next time with more real stories and expert advice.